DBS is about 10%, 20% of my practice, and my passion, the reason I talk about it, is because it's probably one of the best things we do in neurosurgery, and it's the most underutilized. So I know there's orthopods and spine surgeons in the room, but as pedicle screws are overutilized in our world, I think neuromodulation is underutilized, and we not only should spread the word about how good it is, but I think we should be excited about the things that are coming up. So I'm just going to blast through a couple of reasons why we do it that you should all know for your boards, and a little bit of background theory, and then touch on what's exciting and new coming up. So the numbers are staggering. I think with the coming of the silver tsunami, we're going to see more and more patients with neurodegenerative disorders, more Parkinson's, more tremor, and a whole bunch of stuff with the era that we've gotten cardiac disease out of the way. We're getting kind of a handle around cancer. We're going to have functional human beings living into their 80s and 90s. They're doing fine from here down, and from here up, they're disabled. And our society hasn't quite figured out how to manage that population. There's ethics around it. There's literally the management strategies of neurologically disabled patients, and it's not a small population of Downs. It's a lot. We know there's things that are good and bad that lead to Parkinson's, but we still don't know exactly what causes it. Again, I advocate for coffee and not smoking, just to make sure that we're being medically appropriate. We'll run through a little bit of the background and history and risks today. So this stuff started a few hundred years ago when this guy decided that running electricity through dead animals was a way to prove that the nervous system actually ran on electricity. He advocated this, but Luigi unfortunately got chased out of town because he was thought to be resurrecting corpses, and that scared people, and they did not appreciate his brilliance at that time. So not much happened until the 1920s when functional neurosurgery really kicked in. We figured out how to get inside the brain without doing too much damage. Busey, Myers, and Poole really sort of started functional approaches instead of just removing bad stuff, trying to change things and how they altered human physiology and neurophysiology. Stereotaxy really took over in the middle of the century. and I have one of the frames from that era sitting in my office, and it hasn't really changed much. We basically bolt something onto the head, we get some imaging and get an XYZ coordinate system, and we're using that still today to get into the human head. So by the 60s, we were doing a lot of functional neurosurgery for PD. It says 37,000 published cases, but probably quite a bit more that was being done with the community. And that was the mainstay of treatment. And then L-DOPA kicked in, and we basically got rid of functional neurosurgeons. And there was no use for it. We could give medicines, and people would wake up. They made movies about it. It was an amazing era in treating Parkinson's disease. And so for a while, neurosurgery took a back seat. And then in the 90s, when all the patients became resistant to the medication, they came back to surgery because we needed other options. And really, Benabid sort of spearheaded deep brain stimulation in the late 80s, and by the early 90s, we had some FDA approval. So what we do today, again, isn't very different than what we did in the past, but you can see that the head frames have gotten a little smaller. The huge machine here that people would be strapped into is a simple X-ray machine with 4 huge bolts, and they actually would strap patients to this thing and shoot X-rays with ventricular injections. I still can't believe people would submit to that in that era, but it's pretty amazing that they did, and it worked. So that has faded, and we don't do as much lesioning. Maybe with the coming of high-frequency ultrasound, lesioning will come back. In our aging population who are anticoagulants, I think there's going to be a huge need for lesioning again, and ultrasound is probably going to be the primary way, but there's radiosurgical lesioning as well that's currently primary. There was a presentation at last year's Movement Disorder Society from Europe. They've seen a huge uptick in radiosurgery lesioning over the last 4 or 5 years. So I don't know if you're seeing the same here, but I suspect that radiosurgery and ultrasound may grow substantially in the elderly population. As you know, DBS is a 2-stage procedure. Ryder, do you still do everything 2-stage, or are you doing any single stages at all? Generally 2-stage. It is primarily done 2 stages for insurance reasons, because the hospital doesn't get paid for the battery device, which can cost $10,000 or $20,000 if you do it all in 1 stage. The piece about the medical reasoning that makes me feel justified in doing 2 stages is that there's a very small subset of patients who have pulmonary issues or other infectious issues that delay stage 2. And there's also those who take a little bit of a hit with the electrode placement, putting them under general anesthesia for the battery placement in that immediate stage, I think increases the risk and increases their cognitive hit. So staging it makes sense from that standpoint. So I don't feel so bad being a slave of the medical industrial complex. So currently we have a couple of options to do this. We have frame-based options, we have frameless options, we have options in CT and MRI, and it's a little bit dealer's choice, keeping patients awake or asleep. Awake is a bit of a misnomer because they're asleep for most of the procedure. They just wake up for the monitoring and the testing portions. I think imaging-guided surgery is probably going to be the future. And I doubt that MER is going to disappear, because the functional anatomy is still tremendously different than the radiographic anatomy. And as we do functional passes, my case last week, anatomically we were perfect, and we got absolutely no STN. We moved 2 millimeters more medial, and we have a 4.5 millimeter swath of STN. So I just can't bring myself to not do monitoring and expect to get the same results. I believe Kim Burchell's data as far as anatomic placement. I just think we have this tool. There isn't adequate evidence to kind of keep this tool away from patients in the majority of cases. That tiny little spot that we have to hit in the head is it's becoming bigger and bigger with the technology we have. We have more accuracy, and that's what's going to make this easier. That's why it's going to be easy to spread this technology into the community. We'll be able to get more surgeons to do this more quickly. When I was in training, when I was the low man on the totem pole, got stuck in the DBS room because you put the frame on at 7 a.m. and you weren't closing skin till 5, 6 p.m. at night. And you sat there like this as the neurophysiologist moved the little dial, and it was torture. And so that torture probably kept a lot of our colleagues from going into this field. These days, as you see with Ryder's and Pete's cases and most of ours, you can get 2 or 3 DBSs done in a day. It's a pretty low stress case, and people do really well. So I'm hoping that technological advancement and being able to do these things quickly will change the mood and encourage more people to go into this field. The STN GPI debate still looms. Some people sort of force to function one or the other. I think we're becoming a little more articulate about when to use STN, when to use GPI. The overwhelming driver still is the neurologist programming the patient and their comfort with programming in the nucleus. That seems to be, as far as the referrals we get, they seem to drive where they want the electrodes. But most of the time, tremor predominant, we go STN. Non-tremor symptoms, we go GPI. Medication reduction, we go STN. Younger patients, I'm starting to feel a little more advocacy for GPI, because although you don't get medication reduction early, you can do better upgrade programming later on in life. So a couple of little techniques. How does it work? We still have no clue. I go to these meetings every year hoping for an epiphany of some brilliant neurophysiologist to actually show me the map of what exactly we're doing. But we don't know. We know that some circuits are upregulated, some circuits are downregulated. but we still haven't quite figured it out. In the last couple of years, there's some data showing that we're not just affecting gray matter, we're actually causing axonal change and sort of rewiring or rejiggering transmission lines. And I'm hoping we'll know more and more with DTI imaging becoming more powerful in the coming years. But it just works, and we don't know why. Who should consider DBS? Today, the mainstay is for Parkinson's disease. 4 years is the FDA requirement. People like David Charles are pushing earlier and earlier. People with tremor predominant seem to do better. And for essential tremor, it's fantastic. And for dystonia, we're still on HDE because dystonia is a broad array of diseases, and it's less specific than classic Parkinson's or essential tremor. As most centers do these days, we have on and off testing and processing. I won't bore you with that, but good patients are typically more typical Parkinson's disease patients with better health, younger patients, good cognitive function, good family support, and the opposite is the bad patient category. Main reason I love this is we have really, really good randomized control data. In many of the other areas of neurosurgery, we don't have good RCTs that show such a powerful positive impact on these patients and their lives and the lives of their caregivers and sort of their extended support system. We don't see these kind of numbers in much else. I think as far as impact, taking out an epidural hematoma in neurosurgery, taking out a large grade 1 meningioma, and taking out a lumbar disc, as far as benefits to society for the cost, those are sort of the big things we do. DBS is way up there. Can you think of anything else we do that's more impactful than DBS?
Surgery, stroke.
That is true. Yeah, thrombectomy for stroke is becoming significant. The earlier studies showed it, and more studies are coming to prove that it not only improves tremor, but all the downstream effects of Parkinson's disease are being impacted. And this may be because we're rewiring the brain. So if we're, instead of letting certain functions in the brain atrophy by getting people up and moving and re-engaged in life, we're preserving the secondary functions that Parkinson's takes away from these patients. And complication rates are dropping across the board. It used to be in the teens, was quoted, but we're getting lower and lower. And at least in our center, over the last decade, we're seeing sort of a reduction down to what we quote now is about 5 or 6% general complication rate, 1% risk of hemorrhage, which has been consistent, but only about a fraction of those, 0.25% of a percent, that actually have neurologic deficits. What do you quote your patients?
Yeah, I quote 1%, but I agree, it's significantly less than that.
Yeah.
When you kind of permanent neurologic.
Yeah. And this is what scares the community. This is what's keeping neurologists from referring patients for this therapy because, oh, you're going to get a hole drilled in your head and you can have bleeding in your brain and have a terrible stroke. The risk of anticoagulation is multiple-fold higher for intracranial hemorrhage, but everybody gets put on a DOAC. They don't even think about it, but they won't refer for a very impactful treatment. And we have to change that. And that's really on us as people who understand the science or in the field. We really have to spread the word that this is good technology. It is good for our community. It's good for the patients. And we just haven't been doing enough of it. Patients with a good sense of humor come up with things that change about you. So I love this art. And the other effects are out there. The things I try to tell patients is it is not a cure for the disease because we're not sure yet if it makes long-term difference. I think within the next decade we'll be able to say how much of a long-term difference it makes, but it's not a cure. They're sort of like ready for Christmas. I'm going to be all better, but you really have to show them that that's not what's going to happen. It's just going to improve their quality of life to the best on state in medications. New players in the field. So we have had Medtronic for 20 some odd years, and so we now have St. Jude in the game. Boston's coming out next year. The technology is pretty much the same all across the board. The only difference is St. Jude doesn't have their MRI compatibility yet. Medtronic didn't have it for the first 15 years. We were MRIing patients with DBS anyway. The FDA actually said you can't MR patients with just electrodes in place because they didn't test that circuit. And for the first 3 years, we were doing sort of localization studies after electrode placement with MRIs on all of our patients and never had any issues. So I think people, there's also fear in the field fed by regulatory stuff, and we have to kind of advocate against that. The cool stuff that's coming off is directional stimulation. So as we learn more about where to stimulate and how to stimulate, we can redirect electricity now. I know Ryder's done a few cases of this, and this promises to be a big new innovation. So we can use less power, be a little more explicit. It allows the surgeons to maybe be a little less accurate with the placement, because then once you get it in there, you can sort of shoot one direction or another. But hopefully this new technology will be what takes us over. And there's good data that shows neurophysiologically we're activating the more appropriate tissues with directional leads. As we know what the anatomic and physiological and symptomatic responses are to various areas of stimulation, as we learn more and more about that, we can probably fine-tune things. I'm waiting for fuzzy logic circuits to come out where you put the thing in, send somebody home with an app, and they just kind of wiggle something around, and the software learns what's bad stimulation, what's good stimulation, and then slowly tunes them as they go about their life and function. And feedback circuit DBS is going to get us that soon. I don't know how soon it'll be realistic, but soon. Andrew Coe at the university is doing some great work with feedback circuits. And I think at least for tremor, he'll have a good feedback response system within the next 5 years that we can probably go commercial. I don't know if you've heard of anything else that's coming out that's going to.
Well, the PCNS, I think, with Medtronic is going to hopefully lead to that kind of revolution that you're talking about.
Yeah. Yeah, they're using cortical strip for beta band information to feed back, and there's other things as well as far as tremor monitoring, EMG monitoring, gyroscopic monitoring, and that allows feedback into the system that'll help it turn on and off and increase and decrease its amplitudes. So good promise, but there was promise of that in the 90s when we were doing spinal cord stimulator research that was going to be all automated. That's not yet been done yet either. So maybe there are more barriers than hope right now, but we'll see. The programming is becoming a lot easier. You don't have to deal with that archaic Medtronic programmer as much anymore. We have cool apps and cool software that anybody can run. My real fear is some teenager is going to hack grandma's deep brain stimulator and start kind of messing with it because they hack everything else. There's no reason why they wouldn't go and hack this stuff. And the discussion we had at the DBS roundtable is, and this is a good ethical question for you guys to consider. If somebody comes up and says, hey, I like setting X because it makes me euphoric, it makes me high, it makes me feel good, it doesn't treat my Parkinson's as well, but I want that setting for my DBS, how do you answer that? Are we allowed to give them the settings they want because it makes them feel good? You know, we have spinal cord stim patients who say, hey, I know my leg pain is in my right leg, and but I want the stimulation more towards middle because it feels better. And this is happening more and more as we're getting more neuromodulation patients out there. So consider the ethical implications and the practical implications of how we're going to deal with these patient populations who have desires that are incongruous with what we think are sort of medical necessity. And then consider if, you know, in Vegas you can go to the little medical RV and get a banana bag after a night out. Are they soon going to have little medical RVs for programming your DBS parked somewhere so you can go get that? lots of work going on. Just if you look at the uptick in the amount of publications in this field alone, it's amazing. So those of us who are in it can't keep up with the publications in just DBS anymore, let alone neurosurgery. So subspecialization is going to happen. And then I think subspecialization within neuromodulation is going to happen. There's going to be Parkinson's neuromodulation docs, and there's going to be psychosurgery neuromodulation folks. But it's coming. The data gathering is getting better. We're part of Medtronic's international database, which I think is one of the first good efforts at really high fidelity data. I've been impressed with how they've been able to keep their rates of data collection in such a broadly spread effort. Data fidelity is high. The actual data they collect is kind of low. So this is going to be a tool, but before getting involved in any of these large databases, make sure they have the resources, because they're spending millions and millions of dollars, and the only outcome measure they're following is EQ5D. The rest is basically just demographics and background information on these patients. They're not collecting much else. But with that, they've shown the improved quality of life with DBS in a couple of thousand patients. So we're going to have big data supporting our work here pretty soon. So one of the efforts going on at our institution is taking this data and predicting which patients are going to have highest risk. The first set of data analysis only led to significance for predictor for disposition of whether they go to nursing home or home. So that primed the pump for us to consider going bigger, and we're participating with Spokane and getting more data so we can tell each patient what their actual risk of complications are. And hopefully the next step after that, we can tell each patient what their risk of improvement in functional scores and outcomes are. So hopefully we'll get more of this stuff out, and that'll help reduce the anxiety and the fear for a patient population and the referring population. Lots of areas of spread for Parkinson's. I'm sure you've heard about all of these. I won't belabor those. Future of DBS in particular, I think we're going to see technological advancements that reduce the size of the device, improve the programming, improve battery life, procedure-related stuff. I bet you we'll get to a point where this becomes sort of outpatient with minimal risk to the patient. And that 1% hemorrhage risk, I still don't know how we're going to crack that yet. But maybe super high resolution MR imaging that shows the microvasculature and allows us to navigate around it is the future, but we don't know yet. And then expanding to other stuff, the most controversial stuff is psychosurgery, and can we use this to treat alcoholism? Can we use this to treat depression? Can we use this to get psychotic prisoners who are locked away for life made more docile and get them, back into society in a functional way? All this stuff has significant ethical implications, but it's coming. And then on the military side, they're really pushing a lot of money into research for neuromodulation to build better soldiers. And so I don't think it'll be long before we're doing neuromodulation for pain. Why wouldn't you put a preemptive pain neuromodulator into your soldiers so they don't feel pain and they can fight harder and go longer? So all sorts of ideas are thrown around in this arena, and we have to consider the ethics of it. I'm most excited that we are actually able to do this stuff and connect computers with the human brain, and I'm hoping that we see more of this within our lifetime. And with that, I'm going to let you guys get to your Wednesday, and I know you got a busy day ahead. Thank you for having me here, and hope to see you all around soon. All right, thank you so much.